Hi, this is Dr. Baker Townsend, and I would like to talk to you today about laboratory tests during pregnancy. Initially, when the patient comes in for her first visit, we're going to check her blood type. We're going to see if she's AB, B, or O, and we want to know her RH type if she's negative or positive. We're going to do a general antibody screen to see if she has any foreign antibodies in her blood. These foreign antibodies can be from exposure to blood, such as a previous blood transfusion, or it can be just aberrant where she was exposed to someone else's blood and she picked up an antibody. We will do a CBC with the hemoglobin and hematocrit. We want to make sure that the hemoglobin and hematocrit is not showing us further anemia. We know that pregnancy is a condition which has physiologic anemia. The hemoglobin and hematocrit drop as a result of the extra plasma volume. So every woman is considered in a state of physiologic anemia, but we want to make sure that in her first trimester she doesn't dip below 11 for her hemoglobin, in the second trimester 10.5, and in the third trimester 11. So we're also going to look on the CBC. We want to look at her white count, make sure it's not elevated too much. They go just a little bit above normal during pregnancy. And then we're also going to look at platelets and make sure that she has enough platelets, because bleeding is a huge concern during pregnancy, and we want to make sure that she doesn't have decreased platelets or thrombocytopenia. We'll do rubella titer, make sure that she is immune to rubella. If she is not, we'll tell her to stay away from any sick kids. We'll do a lot of teaching if her rubella titer is negative, because we know rubella is a major teratogen. We'll do a syphilis screening, which is called a VDRL or an RPR. If that screening is positive, we will do a diagnostic test to confirm. We'll do a urine screen. We'll look at her urine. We'll definitely test for UTIs every visit. We'll look for nitrites and blood in her urine. We'll also look for glucose, which could dictate it could tell us that she has gestational diabetes, and we'll look for protein, which could tell us that we have high pressure on the kidneys, and when that big protein molecule's getting pushed into the urine, and that could dictate that we have pregnancy-induced hypertension. We'll do a hepatitis B surface antigen to check for hepatitis B. We definitely need to know if she's positive so that we can have adequate treatment for our baby. We want to HIV screen all women, get them into a program for HIV positive women during pregnancy, which gives antivirals, lowering the load, and many women with HIV are able to have a vaginal delivery. Optionally, we can do a drug screen. We need to be very serious about drug screens, especially in the face of the oxycodone epidemic. Pap smear if she needs it. We start Pap smears at 21 years old, and we do them every 3 years if they're normal, so she may or may not need a Pap smear. And then we can do some testing for some genetic diseases such as sickle cell anemia, Tay-Sachs. Sickle cell affects mostly African Americans. Tay-Sachs affects mostly Pakistani Jews, and then cystic fibrosis for patients with a family history or history of cystic fibrosis. Then later, at 14 to 20 weeks, we're going to do a free cell DNA. These two are non-invasive screening tests, the free cell DNA and the maternal serum alpha-fetoprotein. So we're going to do a free cell DNA, and this will actually give us the sex of the baby, but it will also detect sex-linked chromosomal abnormalities, and also aneuploidies such as trisomy 13, 18, and 21. We'll do a screening test called maternal serum alpha-fetoprotein, or a triple or quad screen. This is again a screening test. It has a very high false positive rate. And we'll do that. This detects, a decreased number would detect a risk factor for Down syndrome and elevation for a neurotube defect. So you guys, This test again has a lot of false positives. So if we got a false positive, we would do an ultrasound to make sure that the dates were correct, because just the dates being incorrect can give us a false positive, and then rerun the test. Now after that, if either one of these tests came back positive, we would send them for genetic counseling and offer them an amniocentesis so that she can make decisions about this pregnancy prior to the 20-week mark. If she is over 35 years old, we will offer her genetic counseling and an amniocentesis to yield information about the fetus. The ACOG, American Ecology of Gynecologists, is now recommending that all women be offered genetic counseling. At about 20 weeks, we will do an ultrasound for anatomy, and to make sure, we'll do it between 18 and 19 weeks, but we like to get close to 20, but we'll make sure the anatomy is correct, and it will yield a lot of information for us to give the mother about the condition of the pregnancy. Around 26 to 28 weeks, on all Rh negative women, we will do an indirect Coombs test. This test will detect if she has made any antibodies against a positive fetus. So if the Rh negative mother has an Rh positive fetus and the mother has made and there has been some type of blood exchange and it is positive, the Coombs test is positive, we will know that we can have some degree of fetal hemolytic disease, meaning the antibody will then cross the mother's from the mother over the placenta to the baby and could cause some lysis of red blood cells. So if the indirect Coombs test is negative, again, this is blood drawn on the mother and detecting if she has made antibodies against a positive blood type. If this test is negative, we will administer the Rhogam around 28 weeks. Rhogam is a medication that prevents it suppresses the immune response. So it will suppress mothers from making antibodies against a positive blood type in the event that she was exposed to the fetal blood from, say, for instance, a trauma like a car wreck and had a placental bleed, an amniocentesis, a bleeding event, anything at all like that. So we want to make sure that she gets this Rhogam at 28 weeks. It lasts for 12 weeks, so it will remain the duration of the pregnancy. We will test again after delivery, but this will protect her for the remainder of the pregnancy from making antibodies against the positive fetus. We'll also do a 50-gram 1-hour glucose tolerance test at 26 to 28 weeks. We know that the human chorionic somatomamotropin, which is the hormone that makes moms insulin resistant, starts to peak around this gestational age. Our body wants us to be a little insulin resistant so that we can pass the glucose on to the baby. Unfortunately, some women are already insulin resistant, or some women are very sensitive to this hormone, and this can cause their blood sugars to go very high. So we'll do a 1-hour screening test. If that is positive, we'll do a 3-hour diagnostic test that will yield us 4 values. That will yield us a fasting, a 1, a 2, and a 3-hour value. If 2 of those 4 values are elevated, she will be diagnosed with gestational diabetes. We'll start on a conservative course, such as diet and exercise, move up to oral hypoglycemics medications, and then we'll move to insulin. At 36 weeks, you guys will do the test for the normal flora group beta strep, which is on 40% of all people's skin. Unfortunately, this particular normal flora can cause a massive infection in the baby. First, we identify patients with this normal flora. We use a big swab their the outer labia and to their anus on their skin. We send it off for testing. If it comes back positive, we tell mothers to report to the hospital as soon as their water breaks so that they can receive IV antibiotics, which can kill this normal flora and prevent meningitis in the newborn. We'll also do a repeat, I'm sorry, having a hard time seeing my screen, a repeat RPR-VDRL, which is a syphilis screen. We have a rise in syphilis, unfortunately, in 2017. So the American College of Gynecology and Obstetrics has told us to make sure and screen those who have not been screened. So we've screened for years, but we're just having a lot of people drop in with no prenatal care. So we need to be cognizant that we're having higher rates of congenital syphilis. We'll do a CBC just to make sure hemoglobin and hematocrit's okay, her obviously her white count and her platelets, because we know she's going in for delivery. And then we'll do another gonorrhea and chlamydia screen just in case she has been exposed, and we need to get her some additional antibiotics to clear that up before she goes into delivery. If you have questions, please ask your questions on the discussion board, and I'm happy to answer you. Thank you so much.